everyone. In this video, I'll be talking about GERD, gastroesophageal reflux disease. So I'll cover the pathophysiology, the clinical signs and symptoms, the management, diagnostic testing, the alarming symptoms, the complications, along with the treatment associated with GERD. So to start off, let's talk about some of the risk factors associated with GERD. The common risk factors is obesity, pregnancy, smoking, and alcohol intake. Now, these can result in a decreased tone or excessive transient relaxation of the lower esophageal sphincter, or it may cause anatomic disruption of the gastroesophageal junction, especially due to hiatal hernia. And hiatal hernia itself is very common in obesity and pregnancy. So, how does patients with GERD present? The classic symptoms are regurgitation of acidic material in mouth, heartburn, orinophagia, which may reflect reflux esophagitis, and extraesophageal manifestations as cough, hoarseness, and wheezing. Okay, so uh, these manifestations are quite important because these may indicate some complications such as asthma, okay? And also because of the acid reflux in the mouth, it can result in laryngitis and erosive esophagitis, Barrett's esophagus, strictures, and these are the complications of GERD. So the best initial treatment would be lifestyle modification and along with dietary changes and some medications like proton pump inhibitors and H2 receptor blockers. Remember that sometimes patients with GERD can also present with chest pain, and chest pain must be further evaluated as it mimics ischemic chest pain. So you would do a EKG or any cardiac enzymes to rule out any ischemic cause of chest pain before you come to a conclusion of GERD, right? And also you would educate the patient to cut down on alcohol intake because of its risk of decreasing the lower esophageal sphincter tone and worsening the symptoms. Okay, so let's talk about the diagnostic tests. So your diagnostic approach is basically the clinical presentation. Okay, so if the patient has those classic presentation features, regurgitation of acidic material, heartburn, you don't need to do an extensive workup like this. Okay, your diagnosis is clear, so you don't want to do any extensive workup. Provided you always want to rule out cardiac etiologies. Okay, so if you have any suspicion of cardiac causes, you would first rule out those before coming to a conclusion of GERD. Okay, sometimes patients may have atypical presentation. Uh, then in that case, you may do an endoscopy with biopsy. Okay, and you may also do a 24-hour intraesophageal pH monitoring. That is a gold standard diagnostic test, but it's not always indicated. It's only done in few cases. It is when the patient does not respond to your initial treatment with proton pump inhibitors, or patient in whom cough does not respond to proton pump inhibitor treatment. Then that is when you want to reevaluate the diagnosis, and so you would do a 24-hour intraesophageal pH monitoring. If the question asks you about what's the gold standard diagnostic test, then you would pick 24 hours intraesophageal pH monitoring. And if the question asks you what would be the most initial test, okay, if the diagnosis is clear enough, then you depend on the clinical presentation, okay? And if the symptoms are atypical, then you would do an endoscopy with biopsy. So what is the management? Always, for all patients, you recommend lifestyle modification. You want to avoid triggering food like fatty food, caffeine, acidic, and alcohol intake. Stop smoking. Sleep in an elevated position. And antacids. For mild to intermittent symptoms, you may prescribe antihistamine, such as cimetidine, famotidine, or ranitidine. For moderate to severe symptoms, you may prescribe proton pump inhibitors, which includes omeprazole or lansoprazole. Some of the side effects associated with chronic use of proton pump inhibitors may be pneumonia, because this causes suppression of acid protective in the alveoli, and that may cause uh, growth of bacteria. Okay, so pneumonia due to chronic use of proton pump inhibitors, Clostridium difficile infection for the same reason. It suppresses bacterial growth. Hypergastrinemia, fractures because proton pump inhibitors uh, uh, can inhibit calcium uptake as well. By it suppresses the action of the osteoclasts, and so fractures can happen by due to chronic use of proton pump inhibitors. And also hypomagnesemia is one of the complications of proton pump inhibitors. So if all your medical treatment doesn't work, then you would do a surgical intervention like fundoplication. Okay, so that is the medical management of GERD. Sometimes, let's say you treat your patient with proton pump inhibitors once daily for 8 weeks. If that doesn't improve the symptoms, then you want to escalate your treatment to twice daily. So that would be a high dose. Twice daily of PPI again for 8 weeks. Okay? So basically, it's a step up therapy. All right? So that is how you treat GERD. Let's solve a question related to this. So you have a 56-year-old woman who presents to her primary care physician complaining of heartburn, belching, and epigastric pain that is aggravated by coffee and fatty food. She states that she has recently been having difficulty swallowing in addition to her usual symptoms. What is the most appropriate next step in the management of this patient? Would you try proton pump inhibitors? You do a Nissen fundoplication, or you recommend lifestyle changes, or try H2 receptor antagonist, or you would do an endoscopy. Now, this question really gives away the diagnosis. It is GERD because of heartburn, belching, epigastric pain aggravated by coffee and fatty food. This is giveaway, and therefore the diagnosis is GERD. But what is important is this part of information: difficulty swallowing. Difficulty swallowing is a red flag, okay, and especially in this age group. So, dysphagia in patients who present with GERD-like features, the most appropriate next step of management in this patient would be an upper endoscopy. So what are the indications of upper endoscopy in patients who present with GERD? So know the alarming symptoms. When should you, the patient, be referred for EGD or esophageogastrogrudinostomy? Okay, 6 reasons to go for endoscopy: dysphagia, unexplained weight loss, gastrointestinal bleeding, odynophagia, iron deficiency anemia, chest pain, non-cardiac origin. Okay, so these are the alarming symptoms. That is when you send the patient for an endoscopy. So what are the complications associated with GERD? One is Barrett's esophagus, esophageal cancer. Actually, Barrett's esophagus may progress to esophageal cancer, esophageal ulcer with bleeding or perforation, a peptic stricture, or pulmonary aspiration. Okay, so let's solve a question related to complications of GERD. Okay, so a 33 years old Caucasian male presents to your office and complains that solid food sticks in the chest. Okay, this is important. Solid food sticks in the chest. He says that he has to chew food more carefully, take more liquids with meals, and swallow small portions. He recalls having a similar episode several months ago, but which got better following a diet. Now, he has had periodic chest pain behind the sternum for the last several years, denies any recent weight loss, abdominal pain, nausea, vomiting, diarrhea, constipation, black stools, and lumps. He smokes 1 pack of cigarettes daily and consumes alcohol occasionally. He is currently not taking any medication. Which of the following is the most likely diagnosis in this patient? Okay. Now, the presentation is quite atypical. This is certainly dysphagia because this patient has difficulty swallowing solid food and it sticks in the chest. Okay, this is dysphagia for sure. Okay, now the red flags have been, there are no red flags uh, like weight loss or GI bleed because of black stools, right? There's nothing, no family history, so there are no red flags. And in fact, the patient is quite young. But this patient says that he recalls having similar episodes, okay, months ago that got better after following a diet. But it was much less severe. Now it has progressed, okay? So this basically, he has had this periodic chest pain behind the sternum for the last several years. So, this sounds, this kind of a chest pain which resolves following a diet, it sounds like GERD, okay? And especially in this young age group who is a smoker, occasional alcohol consumer, okay? So this sounds more like GERD, okay? Now, this GERD has got worse. How is the patient presenting now? He's presenting with progressive symptoms. Solid food sticks in his chest. So dysphagia due to GERD. Okay? Now this calls for an endoscopy. You definitely need to do an endoscopy to rule out any obstruction. Okay? So esophageal dysphagia, the best initial test would be to go for an endoscopy because you want to rule out any adenocarcinoma or you want to rule out strictures. Okay? So uh, so you do endoscopy and bam, you find out esophageal strictures. Now, why is it esophageal stricture, not adenocarcinoma? Well, because this patient, okay, is young and he has no features of, cachexia, like weight loss or um, lumps. So, in that case, you may rule out adenocarcinoma, definitely not squamous cell carcinoma. And Barrett's esophagus, no, as well. Achalasia, why not achalasia? Because it's not a, you know, dysmotility syndrome. Doesn't sound like dysmotility at all. So it's more like an obstructive dysphagia and esophageal stricture as a result of GERD, which got worse. Okay, it's quite an unusual or atypical presentation of GERD. So, like how we said earlier, if there this is an example of atypical GERD. So if you have any patient who presents with atypical symptoms of GERD, you would do a biopsy. Okay, this is definitely a classic atypical symptom. Okay, so uh, then it is important to identify the non-classical presentation of GERD, including a periodic retrosternal chest pain that can mimic angina, and this resulting erosive esophagitis may cause transient dysphagia, which may result in peptic stricture if left untreated. Okay, so peptic stricture formation is a well-known complication of GERD, and that can cause an obstructive dysphagia. So in this case, a typical clinical picture of obstructive dysphagia is given, which is difficulty swallowing solid food, prolonged and careful chewing, and swallowing small portions. Okay, so really there are two main causes of obstructive dysphagia. One is esophageal cancer and strictures. Okay, so very classic atypical GERD. Okay, now we'll go on to the next one, which is Barrett's esophagus. Now, what is Barrett's esophagus? Barrett's esophagus is basically characterized by metaplastic columnar epithelium replacing the normal stratified squamous epithelium, and Barrett's esophagus may progress to esophageal adenocarcinoma. Okay, so on endoscopy, how does this appear? The columnar epithelium appears reddish versus the squamous epithelium looks pale and glossy. Okay, so the salmon colored with a velvet-like texture goes more with metaplasia. Okay, Sometimes it is the columnar epithelium with goblet cells. Okay, so that's how the classic presentation would be. So you would do an endoscopy, all right, and then so how do you assess Barrett's esophagus? So chronic GERD of frequent symptoms and any of the two of the following, okay, such as age more than 50 years, male, white, hiatal hernia, obesity, current or former tobacco use, first degree relatives with Barrett's esophagus or esophageal adenocarcinoma. The mnemonic for this is wish for home, so we can revise this again. W here stands for Vites, S here stands for smoking tobacco, H here stands for hiatal hernia, for the F here stands for 50, H for history of cancer in the family, obesity for O, M for male sex. Okay, so pictures are always good to remember. 50, hiatal hernia, male, white, and obese, smokers, and family history. Okay, so those are the red flags for Barrett's esophagus. So any patient who has GERD, who presents with the progressive symptoms or who has these risk factors, what do you do then? Yes, you need to do an endoscopy. Okay, endoscopy for Barrett's esophagus. Okay, so when you do a screening endoscopy for Barrett's esophagus and you find metaplasia, then you want to know if there is any dysplasia. Okay, so if there is no dysplasia, then you would do less frequent surveillance endoscopy. So in every 3 to 5 years, along with proton pump inhibitors. However, if you find dysplasia of low grade, okay, then you would do the endoscopy more frequently, like in every 6 to 12 months with PPI. All right, and sometimes if there is potential uh, any potential reason for its progression to high grade dysplasia, then you may also go for endoscopic eradication, like ablation. Okay, or if patient has high grade dysplasia, then definitely endoscopic eradication therapy. Okay, and the endoscopic eradication therapy maybe with ablation or mucosal resection. Okay, so these are the complications of GERD, Barrett's esophagus, and the strictures, and the atypical presentation of GERD, the alarming symptoms of GERD, and the entire workup related to GERD. That is all. Thank you, and subscribe to my channel and hit the like button. Thank you.